Let's tackle the warm-up review. First question, which adult structures are derived from the third, fourth, and sixth aortic arches? So the third aortic arch gives rise to the common carotid artery and the proximal part of the internal carotid artery. The left fourth arch gives rise to the aortic arch in the adult, and the right fourth arch gives rise to the proximal part of the right subclavian artery. And then the sixth arch gives rise to the proximal part of the pulmonary arteries and the ductus arteriosus. And remember that the fifth aortic arch doesn't give rise to any adult structures. Next, what agents stimulate the release of norepinephrine from the presynaptic bouton? So the three different agents are amphetamine, ephedrine, and tyramine. And the last question, what agents potentiate the action of norepinephrine by inhibiting its reuptake into the presynaptic cell from the synaptic cleft? So we had cocaine, tricyclic antidepressants, and we also mentioned SNRIs. Now let's get started with the lecture.
Hello everyone and welcome to another Step 1 video. Today we'll be talking about beats, which gives me a great opportunity to show you all my free-form rap style. With me always is DJ Funky Travis.
I'm not a DJ, I'm the videographer. Are you sure you want to do this?
Shut up, Travis. Today you are DJ Funky, and yes, I want to do this. I've got sick rhymes and students will love them. Now, throw down a delicious beat, please. No, that's not funky enough. How am I supposed to get down to that? Nope, that's got no flow potential. Zero flow. Come on, man. Well, are you messing with me now? Do I need to take the funky out of your name, Travis? I will do it! Now, the next beat you drop better be so funkalicious that I want to eat it. All right. Winky Bach. Makes me think of Chewbacca. Okay, Travis, I think you're just not ready for this yet. You need to work on your treble and your faders and, I don't know. Sorry, students, no rapping today, I guess. All right, so let's move on to the ECG tracing. So this is a 3-star topic. Some of you might have as many as 2 or even 3 ECGs. Some, maybe not any ECGs at all. It actually varies from year to year and student to student. So it is variable how many you're going to see on your test, but you do need to be able to recognize the different rhythms. So first we're going to start with atrial fibrillation, AFib. So AFib is the most common cardiac arrhythmia, and AFib is described as irregularly irregular. The RR intervals follow no repetitive pattern. Now the ECG will show a great deal of randomness to the QRSs. The rate can be normal, but it's often increased. Now, another very important aspect of AFib is that there are no discrete P waves, and I'll explain in a minute why we don't see those P waves. So remember, when looking at an ECG that may be AFib, maybe not, the 2 things you need to see is an irregularly irregular rhythm, and then again, no P waves. Remember that. So what causes atrial fibrillation? We actually don't know exactly. We think that in AFib there is a triggering signal that arises from the pulmonary veins. But we have identified some risk factors. They include things like hypertension. So AFib patients, 60-80% of those patients have hypertension. Also cardiovascular disease, so 25 to 30%, and then heart failure, about 30% in that one. So each of these is associated with left atrial dilation, which seems to increase that probability of abnormal electrical firing from the pulmonary veins. Now, when AFib is present, there's too much atrial electrical triggering. Then you don't get really that nice coordinated atrial contraction. I try to imagine sort of like the atria just sort of quivering there with excitement, but it never gets out a nice normal squeeze. And you can see this in some ECGs. The baseline isn't very smooth. It kind of looks a bit jagged, but a very, very low amplitude. And because we don't get a coordinated contraction, we don't see, again, those really nice P waves. Now, as we said before, the rate can be normal or increased. The atria are firing off a multitude of signals. Now, often this can result in tachycardia. Now, many of those signals get through the ventricles and then you get that rapid ventricular rate. Now, this is often the presenting symptom. Patients will complain of tachycardia, shortness of breath, a fluttering in their chest, maybe even angina. So what are some of the other consequences of AFib? Well, if the atria can't generate a coordinated contraction, then there can be pooling of blood in the atria. So what does stagnant blood want to do? Well, it wants to clot. And that's why atrial fibrillation is so concerning, because the atria aren't contracting, that pooled blood forms a clot, and then the clot can dislodge and then embolize to other sites. Now, it may travel to the right ventricle and then to the lungs, causing a pulmonary embolism. or if there's maybe a patent foramen ovale, or if the clot forms in the left side of the heart, the left atrium, then it can dislodge and embolize in the brain, cause a stroke, or then maybe potentially travel to other parts of the body and embolize there. So, how do we treat AFib? Well, first you need to know if this is new or if it's chronic AFib. If the atrial fibrillation is less than 48 hours old, you can do a synchronized cardioversion. You synchronize the cardioverting with the QRS segment so that you are basically resetting the normal rhythm of the heart. Now again, you can do this only if this is new AFib. So why don't we cardiovert an older AFib, greater than 48 hours? Well, we just talked about clots forming in the atria. So what happens if the heart abruptly starts having big, nice coordinated atrial contractions? Well, you run the risk of dislodging the thrombus and then causing an embolus. So if you have a clot in the atria, you do not want to coordinate an atrial contraction at that point. So what about an AFib that lasts longer than 48 hours, or maybe just an unknown duration? Then the patient will need anticoagulation therapy. So what drugs do we use here? Well, first and abruptly, we're going to use the heparin or enoxaparin. So that's the low molecular weight heparin. Now at the same time, we also start warfarin. Now once that warfarin becomes therapeutic, and usually that takes several days, we generally stop the heparin or the enoxaparin, and then we're going to continue that warfarin indefinitely or until further treatment is decided. So what else do we do for chronic AFib? Well, there's two strategies here that we use for chronic AFib: rate control and rhythm control. Now with rate control, you're going to do that same anticoagulation. We want to make sure that we don't have any clots that are going to form or dislodge. And then two, we're going to make sure the patient doesn't go into supraventricular tachycardia. So what are your rate control drugs for atrial fibrillation? Well, digoxin, kind of an older drug, don't use it quite as much, but we definitely use beta blockers a lot and calcium channel blockers. Now, with rhythm control, you're trying to actually bring that atrial fibrillation back into normal sinus rhythm. Now, what drugs are used most often here? We use antiarrhythmics. We use sotalol. We use amiodarone. Those are big ones. These are potassium channel blockers. Flecainide is a sodium channel blocker that's also used quite often. Now, why would you do rate control maybe versus rhythm control? Well, both of these strategies have very similar rates of morbidity and mortality. Now, rate control may be a little bit of a simpler regimen. Patients who are over the age of 65, who are asymptomatic, tend to do really well on this regimen. Patients who are younger or who are maybe more symptomatic may benefit from rhythm control. AFib can be uncomfortable and can lead to, again, that supraventricular tachycardia. All right, let's move on to atrial flutter. So atrial flutter is actually pretty easy to identify on most ECGs because it has that very classic sawtooth pattern. So if you see an ECG with a sawtooth pattern, that in general is going to be atrial flutter. Now, you do have distinct P waves here, but there are just a whole lot of them and you may not be able to see them very well. AFib has no P waves and it's irregularly irregular. A flutter, again, has the P waves and it's going to look a lot more regular. Here you do have atrial contractions. However, because of that elevated rate, there may not be enough time for the ventricles to fill. So in that respect, it actually can look and feel kind of similar to AFib. But overall, A-flutter, not quite as severe as AFib. And just how fast are these atria contracting? Just for reference here. Well, the amount of atrial contractions taking place with AFib, somewhere above 300 beats per minute. Then for A-flutter, slower, somewhere between about 220 and 300 beats per minute. All right, so now let's move on. Let's talk about AV blocks. So AV blocks are looking a lot here at PR interval. That's going to be the star of this part right here. So let's first talk about a first degree AV block. This is just going to be a prolonged PR interval, so greater than 200 milliseconds. So this is bigger than 5 little boxes or one of the big bold boxes that you often see on EKG paper. So this is a pretty benign condition and is often asymptomatic. The only reason why it might be a problem is that you are more likely to go into second degree heart block if you already have a first degree AV block. Now, there are a lot of people out there that are on beta blockers or calcium channel blockers, something like verapamil. They end up with a first degree AV block as a side effect of those drugs. Now, if they need to be on that drug, even that first degree AV block can be tolerated and careful monitoring should then just be continued. And here's a tricky question. What bacterial infection can cause an AV node block? Well, the answer is Borrelia burgdorferi, which can cause an AV nodal block. So this is the organism that causes Lyme disease. Moving on to second degree. So second degree heart block comes in two different flavors. You have a Mobitz type 1 and then you have a Mobitz type 2. So Mobitz type 1 AV block has progressive lengthening of the PR interval until a beat is blocked. So a P wave is not followed by a QRS complex. So this also is typically benign and asymptomatic. Now, Winky-Bach is another term for Mobitz type 1 AV block. And don't get confused, Mobitz type 1 is not a first degree AV block. Mobitz type 1 is still a second degree AV block. Now, one way to remember this is that Winky-Bach will give you warning before that beat is blocked. So the W there is to remind you that warning Winky-Bach. Now, the other stupid way that I remember this is a cheerleader cheer. Longer, longer, longer block. That's a case of Winky-Bach. So I don't know, whatever way works for you. So let's move on to Mobitz type 2. This is a bit more problematic. There is no warning here. There is a blocked beat that has no precursor warning, no precursor lengthening of that PR interval that we saw in our type 1 here. So it is abrupt. So again, everything looks normal at first. There are P waves followed by QRSs, and the PR interval is not fluctuating, and then you just lose a random QRS after a P wave. So there's no warning in a Mobitz type 2. Now, the reason why Mobitz type 2 is problematic is that it can progress to third degree heart block, and often these patients are treated with pacemakers. So let's move on. What is that third degree heart block? Well, this is where the atria and the ventricles beat independently of each other. Both P waves and QRS complexes are present, but there is no correlation between the P waves and the QRSs. So the SA node is not communicating with the AV node. And the atria are beating on their own, and the ventricles are beating on their own. So they're kind of like two neighbors that aren't talking to each other. They're just doing their own thing. Now, the atrial rate is going to be faster than the ventricular rate, and this is usually treated with a pacemaker. Now, remember that the other one that required that pacemaker was that Mobitz type 2. And again, don't forget Lyme disease. So Lyme disease can result in a third degree heart block as well. And often you'll see third degree heart blocks with narrow QRS complexes. So this is because you're actually still depolarizing through the AV node. However, there can be a ventricular focus which would potentially result in a wide QRS. So about 2/3 of these are going to be narrow complexes. About 1/3 of these cases are going to be wide complexes. Let's move on to Wolff-Parkinson-White syndrome. So this is also known as ventricular pre-excitation syndrome, where you have an accessory conduction pathway from the atria to the ventricle that bypasses the AV node. So that AV node is acting to delay the signal to the ventricles to give them time to fill with blood. So it's there to delay. Now the AV node also acts to keep the heart rate normal. So if the atria are beating too fast, then that AV node can simply block some of those signals so the ventricles then don't beat too quickly. But in WPW, we have a sneaky bypass between the atria and the ventricles that ignores the AV node. Now, the most famous one is called the bundle of Kent. Now, there are lots of different accessory pathways, but the bundle of Kent is the one that's the most common and most well known. So, as a result, you have an early ventricular depolarization that looks like a delta wave. A portion of the ventricle is depolarizing before the signal gets to the other part of the ventricle through the AV node and the bundle of His and Purkinje system. So, as a result, ventricles begin to partially depolarize earlier, giving rise to that characteristic delta wave. Now, I would be able to recognize that delta wave and know that it is Wolff-Parkinson-White. Now, the reason why it's important to identify WPW is because it may result in a re-entry current leading to a supraventricular tachycardia. Re-entry from the bundle of Kent through the AV node system creates kind of a cyclical pattern and causes a very severe supraventricular tachycardia. So what do we give for supraventricular tachycardia? Usually we give adenosine, except in WPW. So this is a good exception here. We do not give adenosine in WPW. We give procainamide. So this is a sodium channel blocker. You could also give amiodarone, which is a potassium channel blocker, and that's to tone down that tachycardia. Now, the definitive treatment is to destroy that abnormal electrical pathway with a radiofrequency catheter ablation. All right, so now let's move on to paroxysmal supraventricular tachycardia. So this is a rapid heart rhythm that originates at or above the AV node. So the signal's coming from the top of the heart. So the name is pretty descriptive. In general, there are two mechanisms, and this is similar to what we just talked about in WPW. There can be re-entry or automaticity. Because this is originating at the top of the heart, most of the time you will see P waves. The rate can get upwards to about 200 or even more. Also because because the signal is originating at the top of the heart, we see narrow QRS complexes. So overall, the EKG is going to look pretty normal, except that that rate is very elevated. Now, another less known arrhythmia is Brugada syndrome. So this is actually a genetic problem. So this is an autosomal dominant disorder that is found more often in Asian males. Now, on the ECG, you'll see a pseudo right bundle branch block. You may also see ST segment elevation in the precordial leads V1 through V3. Now, the big issue with this syndrome that you should probably remember is that it is linked to sudden cardiac death. So the primary treatment is an implantable cardioverter defibrillator. So next we're going to talk about ventricular arrhythmias. So these are a bit easier to understand and come in fewer varieties. The first topic is on ventricular premature contractions, or beats. Often we just refer to these as PVCs, so you'll hear me say that. So premature ventricular beats or contractions are early occurring widened QRS complexes that have a bizarre morphology, which is markedly different from the sinus QRS complex. Now, most often they are the result of micro re-entry at the level of the Purkinje fibers, which generate a premature complex due to a single transmission around this circuit. So the signal is coming from below the level of the AV node. Now, the electrical signal is not going through the usual avenues, and that's why we see kind of this fat, crazy looking QRS. So in general, there's not going to be a P wave identified before a premature QRS complex. The QRS complex of a PVC is widened, kind of bizarre looking, often even notched, with a QRS duration greater than 0.16 seconds. So that's greater than 4 boxes. In a normal QRS, it really should be less than 3 boxes. So this is pretty big. Now, a couple of terms that you should know. Ventricular bigeminy is present when a ventricular premature beat follows each sinus beat. Ventricular trigeminy is present when 2 sinus beats are followed by the ventricular premature beat. Now, most of the time we don't need to worry about PVCs, and treatment is directed at eliminating really severe symptoms associated with palpitations. So really no study has shown that eliminating those PVCs with anti-arrhythmic drug therapy reduces the risk of arrhythmic death in patients, even with structural heart disease. Next, let's move on to ventricular escape rhythm. So an escape ventricular beat or rhythm occurs when there is failure of the sinus and AV node to generate an impulse. So the top of the heart is not doing its job very well to provide the bottom of the heart with enough signals to produce a normal ventricular rate. So the ventricles are just sitting there waiting for a signal from that AV node, and after enough time, the ventricles kind of get tired of waiting and decide to make a signal of their own to get the ventricles pumping. Now, there is an absence of P-wave activity, and the QRS complex is widened, which resembles a PVC. Now, usually you'll see a kind of decently long pause and then a QRS that looks like a PVC is going to come up. Now, persistence of this activity leads to multiple successive ventricular complexes representing an escape ventricular rhythm with a rate that is slower than the normal sinus rhythm that you normally see. Now, in cases of complete or third-degree heart block in which there is sinus node activity but failure of conduction of that AV node, and then you might get something called a junctional escape rhythm where the AV node is the pacemaker. The QRS segment in this case are going to be narrow because that AV node is able to coordinate a fast conduction through the ventricles. Now let's talk about ventricular tachycardia. So ventricular tachycardia is defined as 3 or more successive ventricular complexes. So the signals are coming from the ventricles, but instead of being slow, like we just talked about a second ago, this rate is very fast. So non-sustained VTach is a series of repetitive ventricular beats which have a duration of less than 30 seconds. Sustained VTach lasts for more than 30 seconds. Now the rate of VTach is generally greater than 100 beats per minute, but may vary widely. And the rhythm is usually regular, although there may be slight irregularity of those RR intervals. Now the width of the QRS complex is generally greater than 0.16 seconds, which is widened. So how would this differ from supraventricular tachycardia? Well, remember that supraventricular tachycardia is originating in the atria. Therefore, those QRS complexes, again, are going to be normal, not widened. And then supraventricular tachycardia can become serious, but generally patients are not about to die. Sustained polymorphic VTach will lead to immediate hemodynamic collapse. Big deal. So emergency asynchronous defibrillation is required for survival. Moving on to torsades de pointe. So this is a very specific type of ventricular tachycardia that is characterized by shifting sinusoidal waveforms. Sinusoidal is what you got to remember here, and that's on that ECG. So this is a ventricular rhythm, so it has a very wide QRS. It is a tachycardia, so it's very fast. Now the amplitude, and this is the important part, of the QRS changes. So it's very small amplitude, then very large, then very small, and then very large. So it looks like a ribbon that has actually been twisted. That's why it's called torsades de pointe. Now it is twisting of the points, twisting of a ribbon that's creating that sinusoidal pattern that you're going to see on the ECG. Now unfortunately this can progress to VFib, which is why it is so dangerous. Now anything that prolongs the QT interval can predispose to torsades. There are certain drugs that are known for prolonging that QT interval. These drugs should not be given to patients that already have a prolonged QT. Now, a few I want to mention include things like macrolides, so antibiotics, erythromycin is an example there. Anti-malarial, so chloroquine, mefloquine. Antipsychotics like haloperidol, risperidone, methadone is used for opiate addiction and heroin addiction. The HIV protease inhibitors and a lot of the antiarrhythmics themselves, so the class 1A, and also the potassium channel blockers. So a lot of the antiarrhythmics, unfortunately, can actually cause arrhythmias. But the 1A sodium channel blockers and those potassium channel blockers can cause torsades specifically, so try to remember that one. So how do we treat torsades? Well, you treat torsades with magnesium. For someone with just low magnesium, we'd give magnesium over a few hours, but here you're going to push that magnesium very quickly to correct this arrhythmia. And then we have ventricular fibrillation. So this is a completely erratic rhythm with no identifiable waves. Remember when we talked about AFib looking like a quivering pair of atria? Well, imagine what would happen if you had a pair of quivering ventricles without normal contraction. So like sustained VTAC, this will lead to hemodynamic collapse and requires emergency asynchronous defibrillation right away. So these patients are going to die unless they get an abrupt correction to their rhythm. So you start CPR with ACLS protocol. Hopefully you have a defibrillator close by, otherwise it's not going to go very well for them. All right guys, that brings us to the end of our video part. It's time for that end of session quiz. Try to answer those on your own and then we'll go through them together. First question, what is the initial treatment for ventricular fibrillation? So remember, these patients are dying. So CPR, defibrillation. So that's as laid out in the ACLS protocol. The protocol also calls for certain medications, but for step one, you really just need to know that VFib is a rhythm that needs to be shocked. Next, what are the major characteristics of atrial fibrillation? So tachycardia, usually, but not always. Irregular rhythm, that's a big part. And also remember, no P waves on that ECG. Next, what is the hallmark of a third-degree heart block? So in third-degree heart block, there is no correlation between P waves and the QRS. They are completely out of sync with one another. Next, what drugs are known to prolong the QT interval, increasing the likelihood of torsades in those that are at risk? So remember the macrolides, remember chloroquine, remember haloperidol, risperidone, remember those protease inhibitors, HIV drugs, remember the class 1A antiarrhythmics like quinidine, also the class 3 antiarrhythmics, think of sotalol and amiodarone. Next, what are the two different types of second-degree AV block? How do they differ? So there's the Mobitz type 1, which is Winkie-Bach. You remember that Winkie-Bach gives you a warning. So you have progressively prolonged PR intervals and then a blocked beat. Then there's the Mobitz type 2, which has no warning at all. You just have a blocked beat without that progressively increasing PR interval. Next, why is warfarin anticoagulation important in patients with chronic atrial fibrillation? So remember that atrial fibrillation, you don't have normal atrial contractions, so the blood can pool in the atria and cause thrombosis or clotting. Then pieces of that thrombus can embolize. It can break free, travel through the circulation, cause a stroke. So patients with atrial fibrillation are at increased risk of thromboembolic strokes or other embolic events. So we anticoagulate them with warfarin to reduce that stroke risk. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Yo, what's up? You're watching DIT TV, the best place for new music and the highest yield medical knowledge.
We've got more great hits coming your way, but first, we had a request for this new release by Todd Skure, coming out next month.
That's right, so here he is, Todd Skure with The Rhythm of My Heart, only on DIT TV.
across the street, I see your face down in my chest. Heart is skipping away. Is this love that I feel? I'm so glad you asked. Thumping out a rhythm that's entirely too fast. Heartbeat is irregularly dizzy and lightheaded, really scary. But I made some vibe somewhere, some way. Need a calcium channel blocker that would slow me down today. Oh, the rhythm of my heart is beating out of sync. Fibrillation of the atria, I think. Hope that I don't die, but the EKG don't lie, and the doctor says my heart is an AFib. Oh, the rhythm of my heart was beating way too fast, but till tires am it slow me down at last. AFib is not a joke, and I sure don't want a stroke, so I need some more for red and check my PLC.